So we've got quite a day ahead of us. I hope you all had your Wheaties and orange juice. Get the day rolling. So, I want to make sure everybody's in here because before I get started, I'm going to tell you a little bit about what's new at the IMF. And for those of you who are unfamiliar with the IMF, I'm going to tell you who we are and what we do. But you know what? One of the things that I think makes life so much better for all of us in myeloma land is having a support group to go to and not feeling like you're so all alone out there. And support groups happen because some wonderful people decide to step up to the plate and become a support group leader. So I just want to acknowledge this amazing group of people. So if I could ask the people in this room who are support group leaders to please stand up, and I want you to go around the room and tell them where your support group is. So I'm having a little trouble with the lights, so I might not be able to see you. So are the support group leaders standing? Stand up. All right, we're going to start with you. Where's your support group?
Melbourne, Florida.
Melbourne, Florida. Okay. Support group leaders. Orlando. Ken Fabian. Okay. Jacksonville, Florida. So, okay, no, is that a support group or somebody just reaching for something? Okay. Yes, in the back. Tampa, St. Pete. Okay. Over here? Virginia. Okay. Am I missing anybody? Connecticut. All right. That sounds familiar. My home state. Anybody else? So there's a table out here. If you don't belong to a support group and you want to find out where one is near you, because not everybody's from Florida, see them. Kelly's got his table out there. And if you want to start a support group, get with any one of these people and ask them how to do it because it's really, really wonderful. And you don't need any special skills and you don't need any special place. The first support group started when 4 women in the Bay Area decided to get together, and they got together in a coffee shop, and that Bay Area support group turned out to be one of the largest in the country. So all you need is the desire to get together and share information with other people. That's pretty easy. And from what I've seen so far, this is not a shy group, okay? All right, and I also want to thank, you've probably seen the people in the maroon T-shirts. There are ambassadors. They volunteer to help us with the seminar, so I just want to once again thank our ambassadors. Good work. Okay, so let's get started. So how many people are attending a seminar for the first time? Okay, a lot of you. So I'd just like to tell you, first of all, I'm Susie Novis still, and I work for you. And so I thought it'd be good for me to give you a little bit of an update about how this whole thing got started. So in 1988, I was about to be married to that gentleman, Brian Novis, and he was 33 years old, went for a blood test, and something came back, just to raise his life insurance, 33. Came back that something was wrong. I know, I see your face. That was my face. And what the heck could be wrong? And it turned out that something protein, and I thought it was because he was eating too much steak and cheese. I thought it was, protein cholesterol. No. He got the diagnosis after many tests, and the doctor was very compassionate. He called him at work and said, well, we have the results of your test. And Brian said, well, what the hell is it? He said, multiple myeloma. Brian was like, what? He goes, what is it? He goes, oh, it's a cancer of the bone marrow. You've got 3 to 5 years to live. Stop by my office on your way home. And that's how we fell into myeloma land. And he was stunned and shocked and was like, hi, honey, I'm home. Guess what? So it was not a good time, but he decided that he would do something about it, and being a headhunter, he changed the world for myeloma patients. Put together the International Myeloma Foundation, which at that time was 3 people, Dr. Durie, myself, and Brian Novis, and it grew and grew and grew, and today we're huge. But from the very beginning, we always had the mission to improve the quality of life for myeloma patients while we work towards prevention and a cure. And our 4 areas of focus have never changed. Education, because first of all, we didn't know what the hell they were talking about. So we needed to become empowered through education so that we could make informed treatment decisions with our doctor as to what was right for us. That hasn't changed. That's still the same today. Research, because we needed to put an end to this damn disease. Support for everybody in the meantime, and to advocate to make sure that everybody has access to therapy no matter where you live, no matter what your doctor's putting you on, you should be able to have access. So, what have we been doing? So over the years, we've grown and grown and grown. We have people call themselves members. There really isn't anything to join other than the fact that you know somebody that has myeloma or you have myeloma. But today, over 230,000 people around the globe are part of the IMF. They're in 120 countries. We started with the Scientific Advisory Board. That's grown over the years, 72 people. And we also have an International Myeloma Working Group, which is an amazing entity of people, 160 members from about 33 countries. And this body really does amazing work. You're going to hear more about it later. This group has published, well, I'll save it for a little bit, and we've raised a considerable amount of money over the 22 years. So this is just, this is our reach. I mean, we're growing, growing, growing. The yellow is patients, the blue is doctors, and the pale green is nurses. So as you can see, we've just been really exploding. And I have to thank the internet and a lot of different ways that we've been able to reach out to the myeloma community on a global level. First thing people do when they get diagnosed very often is they call our hotline, and that's Debbie, Judy, Paul, and Missy, our 4 hotline-trained coordinators who answer a lot of calls and emails from people all over the world. And they're a wealth of information. So if you haven't been utilizing the hotline, please call. That's a toll-free number, and they're available 9 to 4, Monday through Friday, Pacific time. Okay, so don't call them like your time because they'll still be asleep. They need their beauty sleep, and they look quite beautiful, don't they? That gentleman is Chemo Lee. He's been with me a long time. We send out 20,000 packets of information every year. So you can imagine, you get the diagnosis, you don't know what the hell it is, you're scared out of your mind, then you get this package of all this great information that has so much hope inside. So we really appreciate the fine work that Chemo does in making sure that those packs go out. Myeloma Today was first published in 1992. It's an amazing newsletter. We have an estimated readership of about 70,000 people. It's quarterly and it's free. So if you're not subscribing to Myeloma Today, you can do it at the reg desk. You get the hard copy. I love the hard copy because then you can pass it along to somebody else, or you can also read it online. We don't care where you live. If you have myeloma, we're going to reach out and help you. So from the very beginning, as I said, it was a South African, a Scot, and an American. Guess which one I was? I'm the Scot. No. So we were global from the very beginning, and over time we've expanded with IMFs in Japan, Latin America, Israel, and Europe. And they're all self-sustaining. They raise their own money and support their own activities. We have global initiatives now. That's Greg Brozite. Many of you know Greg from a long time. The lady in the middle is Nadia Eckelbeer. She's now handling our med-ed programs and patient resources in Southern Europe and Western Asia. And Dan Navid joined us a few years ago, and he really handles Asia. So it's a nice Jewish guy from Chicago who used to live in Switzerland, now handling Asia. Makes sense, right? We also have affiliates, people who want to be kind of like autonomous but want to also have a link to us. So there's the Czech Myeloma Group, Myeloma Canada. We have a guy here from Canada. Where's my Canadian? Okay, do you belong to, do you work with Aldo in the group up there? Okay, well, they're a wonderful group. And we also have the Shirinzi Myeloma Foundation in Italy, which I think we all should go to because they have great wine and pasta. What's not to like about Italy? So over the years, we went from, a phone and everything in hard copy to cyberspace. So we're on Facebook, we tweet, we have wonderful blogs. And as I mentioned the other day, you should really read, you should read all the blogs, but Dr. Durie's blogs on food is amazing. And, who would think that a Scotsman, they're not known for their food up there, would have a lot to say about food, but he does. And we also do webinars and webcasts, so check it out. We now have over 122 publications in our library. They're updated every year. That's a huge responsibility. It's a huge job. But we want to make sure that when you get information, it's the most current and up-to-date possible. And we all don't speak English, so we have publications in many languages. For example, the ones you see listed here. So I'll give you a minute because there's a lot. Okay, I have a photo you can insert. Okay, cool. Ta-da! You used to always check your slides before you put them up. Anyway, we do 4 patient and family seminars a year. We held the first patient and family seminar in 1993. Dr. Kyle was one of the faculty members along with Bart Barloghi and Brian Durie. That was the first one, and since then we've been holding them all over the world. So this year, guess what? We're doing one in Boca Raton. Isn't that amazing? So if you can't get enough, you can come to the Bay Area March 15th to 16th, Chicago August 9th and 10th, and Philadelphia the 23rd and 24th. And then Kelly Cox, my colleague and dear friend, he's been running this program called Regional Community Workshops. They're a shorter program, half day, and they're in the cities that you see there. So, it's always good. Just keep going because you know what, you hear things and you get some of it, but you don't quite understand all of it. So the more you go, the more it makes sense. We also have a wonderful team of support group leaders. Robin, Kelly, Nancy, Ann, and Sue. Andy retired this year, and they're wonderful, and obviously we've got Robin, Kelly, Ann, and Joni here, so if you want to find out about a support group, start a support group, or just chat with them, please do so. And each year we have an annual support group leader summit. It's held in July in Texas, where it's hot as hell, but you can get a great rate in July, because nobody wants to go there. So we never go outside, because if you step into the swimming pool, you'll cook. But it's really great, and they get together and really share information, and we have little workshops on how to run a group for the newbies and so forth, and it's just a really wonderful event. The website, look at that stat. Our website, multilingual, had over 345,000 visits and over 1 million page views, and our website is so robust, and I really want to thank Mike Katz for getting us into that world many years ago, and my dear colleague Abby for maintaining the website. It has everything you possibly would need to know, and you could spend hours and hours on it and still not see everything. One of the new things that we started is the 10 Steps to Better Care, and that was the idea of Dr. Durie. And that's on our website, and it's by now had over 170,000 unique visitors. So it's everything that a doctor, a nurse, or a patient needs to know. Takes you from diagnosis all the way down to new trials. And those are the page views. So you can see this is a very robust part of our website, and it's the way that we're now teaching. We're teaching the 10 steps. We also have the Myeloma Minute. It's weekly. We now have over 30,000 subscribers. It's free. Every week it comes out, and it's got really 4 key topics. The two are always about something medical, and then 2 are things that are more supportive or of interest. So sign up for the Myeloma Minute, and you can do that at the Reg Desk as well. Then my dear friend Michael Katz came up with a brilliant idea of making the Myeloma Post. He talked about it last night. It's for the iPhone and on the iPad, and this is wonderful. How many people here have iPads? Do you all have the Myeloma Post on it? Yeah. All right, good. We like that. And also on the iPhone. Advocacy. This is Erin Acero and her team, Megan, Amy, and Zena. We really have done an amazing job, they have, in making sure that oral drug parity is passed in those states. They've got 21 states to date, because it doesn't matter how your doctor, whether your doctor prescribes an oral therapy or an IV, you should be able to get that. It should be covered. And so Amy is doing a big, huge push to make sure that the oral parity bill is passed in all states. So get with Amy. She's got postcards, and she's got a whole advocacy agenda plan. So get involved. If not you, who? And it's amazing. It's people like you who go before your state legislator and tell your story that compels them to say, I need to do the right thing. I need to pass this law. So it's very, very powerful. We also are heading coalitions. There's PEAK, Patient Equal Access Coalition, and SPEAK. So PEAK is on the national level, and SPEAK is on the state level. And we've done a lot with that. We're leading this big coalition. We were the we started this coalition. It includes people like the Susan G. Komen, the LLS, and so forth, but it's the IMF leading it. We're really, really proud of that. So here's more about the advocacy initiatives, and get with Amy. She'll explain it to you. So healthcare professionals, we have different groups. We've got the NLB, the IMWG, and each year we do the International Myeloma Working Group Summit. So my dear colleague Diane, this was her brainchild to bring together nurses. As we all know, these novel therapies are fantastic, but a lot of them come with side effects. So what the NLB has done is they've developed the guidelines to overcome the side effects so that you can stay on the therapy and get the maximum benefit from it. And many of you heard the nurse Charisse yesterday who gave a talk. They're great, and they also have publications. They train other nurses, and they're very, very active. So if you want to learn more about the NLB and what they're doing, see my colleague Diane. She'd be happy to tell you more about them. Lisa Paik, she's our Senior Vice President for Clinical Education and Research Initiatives. Each year, she works with Dr. Durie on developing the program for the International Myeloma Working Group, the Global Clinical Trials Forum, works with our Scientific Advisory Board, and there's a big meeting that takes place every December called ASH, American Society of Hematology, and we have a symposium at that meeting. And it really is thanks to Lisa and her very persuasive ability to put together an amazing faculty. And that program enjoys over 700 doctors from around the world. They have to go to school and learn. It's really hard for these doctors to keep up because maybe they're not just seeing myeloma, they're seeing a lot of things. And so we have this amazing educational symposium. We live stream it. You can watch it on the website, or tell your doctor to watch it because he or she could learn a lot. This was a big idea for 2012, to bring together doctors for a debate. So I'm kind of proud of this. This was my idea, and to bring together the Americans, Paul Richardson and Brian Durie, versus the Europeans, Antonio Palumbo and Jesus San Miguel. And the only problem is no one is an American because Durie's from Scotland and Paul's from England. However, doesn't matter. It worked out really well. We did it in June at the time of the EHA meeting, and these things are so because not everybody agrees, and it's good to see the experts debate. Not fight, but just really talk about. Well, I see it differently, and to hear their viewpoints. So these are posted on our website. You can go. They're fun. They're really. I mean, it's really kind of entertaining. Get the popcorn, the kids. Watch the Making Sense of Treatment. So it was so successful that we did it again after ASH, and it will be we'll be doing it again in June at the time of EHA. So look out for that. And this time we still don't have any Americans. We swapped out Jesus San Miguel for Philippe Moreau. So, but nonetheless, they gave a really, really fantastic debate. So the International Myeloma Working Group, this is 160 members, 34 countries. Okay, they have come together and they have written the 33 publications that really are the recipe for any practicing clinician to know how to treat myeloma patients. This is unprecedented in the world, in any disease group. These people come together as a group each in June, and they form work groups, and they do what they say they're going to do. It started out with 6 people, and it grew over the years. The tenet was you had to come into the room, you had to agree to work collaboratively, and you had to do what you say you were going to do. So their output is unprecedented. No other disease group has this kind of results. So they're writing the guidelines for all kinds of aspects to treating myeloma, diagnosing myeloma, and they're published in the most prestigious papers. So we're really, really proud of this, and this is the work of Dr. Durie and his colleagues that just have really done an amazing job. So this is something you should be involved in and know about and be really proud of. So this is where the Working Groups Summit has been held, and we're not going to these places because, ooh, let's go to Barcelona. The doctors are there anyway because of this EHA, European Hematology Association meeting, so we save on airfare, and so we piggyback to that, and it's just an amazing event. This is a group photo from the 2012 summit. And as you can see, they're kind of hard to see, but I can see Angela Dispensieri there. I see a lot of people that I know, and it's just there's Ray Comenzo. So it's an amazing group, and you'll be hearing more about them. So we also do lab research and translational research. Lab research, we've given out junior and senior groups. grants rather, over 110. And this is something that I think right now we're the only ones in the myeloma space giving out these kind of grants. I think other people have stopped. That was what I heard at ASH. So these grants are really important. Not only do they bring new people into the field, but they give senior investigators just that push that they need, or the extra funding that they need to get these projects really, really moving. Translational research, it's important, shorter time to results, and that's the group, the entities that you see listed there, the working group, the summit, all these different projects that we're working on. Clinical trials. Clinical trials are the only way that we get new drugs into the mainstream treatment. And this past year has been amazing. We've seen 2 new drugs move from clinical trial to approval. And that is unprecedented. And I just want to thank members of the IMF who went before the ODAC committee and gave unbelievable testimony. My dear colleague, Diane Moran, she gave the most impassioned speech I've ever heard, and not to be outdone, Robin, Tui, and Michael, they gave incredible testimony, and it really pushed, and Jim O'Mell, who was on the panel, Amy Wolverton, all IMFers were there that pushed this bill forward so that carfilzomib got approved. That was amazing, and then right on the heels, of course, pomalidomide. So lots going on. Those are our grant recipients from this year. Nice, proud group of people. We all look kind of like squished. I have to Photoshop that better. I need to look taller. And that's my team. So thank you for your attention, and if you have any questions, I'm around all day long, and it's my pleasure to answer them. Thank you. So now, Mike Katz is going to come forward, and he's going to tell you about the interactive, and it's a really cool thing if you haven't participated in that.
Dr. Kyle was there, Susie was there, Brian was there, and I was there. And at that point, I was pretty ignorant about myeloma and pretty scared. It was about 3 years after I was diagnosed in 1993. And since then, I think I've been to more than 50 of these seminars. I think you guys have it a lot better than we did back in the Stone Ages, in that there's a lot more out there in terms of programs. Like the IMF seminars, the internet. So no one really needs to support groups. No one really needs to be alone with myeloma. And the treatments that are available that you'll hear about throughout the day are just incredible compared to what we had then, which was more stones and clubs. Very, very, very limited set of options. So it's a much better world for myeloma patients. And you have that up. Good. So I'm here to introduce the interactive system to you. On your tables, you should have keypads, and what you should do is try to get 1 keypad per patient that you're representing. So if you're here as a caregiver with the patient, take 1 keypad between you. If you're here on behalf of a patient, and make sure you have one. And if you don't have one, please raise your hand. We'll get one to you. Everyone have keypads? Yes? Okay, so what we're going to do with these is during the course of the day, there'll be a couple of times when we break like this to ask a series of questions to you, and we'll see the results on the screen if the system works, which it usually does. So what we'd like to do is to start off with an intro question just to get everyone used to the system. Dr. Durie insisted that I update this slide so it has some new data on it. Okay, so the first question is, which one of my grandchildren is the cutest? So you have those numbers 1 through 7. Please vote for the answer that you want to give. And this first vote's important because I want to get a count of roughly how many of you are out there pushing buttons so we know for the other ones. So good, you had your coffee. We're up over 100. Anyone else punching in? 108. Okay, let's see what our audience survey said. Okay, wow. I'm going to have to bring that back to the parents. You liked Zevi there in the high chair. That's good. Okay, so now we have a series of questions that are the real questions. Is this your first seminar? Vote 1 for yes, 2 for no. And if you're voting and you make a mistake, just push the right number. It'll read the last one that you put in before we call the vote. So we should have something over 110. And there we are. Okay, so it's about half and half, which is pretty typical. Where do you live? And if any of you are having trouble reading the map, ask your wife. I suspect number 2 is going to be the winner, but let's see. Yes, 71% from Florida. We've got 5 from outside the U.S. So raise your hands, who are the non-U.S. people? Get out. No, okay, okay. Okay, how old are you? Now, this is anonymous. We won't publish it. We're just trying to get an idea of the age of the group. So vote 1 if you're under 30, 2, 30 to 39, 3, 40 to 49, 4, 50 to 59, 5, 60 to 69, and 6 if you're over 70. Okay, so that's interesting. 80% of the group are 60 or older, and you'd never know what to look at you. You really look well. Okay, this is a long list, but it's what brought you to the doctor when you were diagnosed? What was that drove you to have an exam? Was it 1, you had some bone pain or a broken bone? 2, some other pain? 3, anemia? 4, fatigue? 5, high protein levels? 6, a kidney problem? 7, infection? 8, a routine physical? Or 9, if it was some combination of all of those things above? Keep both thinking about this one. Okay, the coffee's wearing off. Here we go. Interesting. So 30% bone pain or fracture, 30% routine physical, which is, that number's gone up over the years. The GPs are getting a lot better at picking up warning signs. How long ago were you diagnosed? 1, if it was less than 6 months ago. 2, 6 to 12 months. 3, 1 to 2 years. 4, 2 to 5 years. Or 5, if it was more than 5 years ago. Okay, wow, 40% of you out more than 5 years. Cool. So, yeah, you would have seen that a couple of years back. That's a good thing. Have you ever been diagnosed with another cancer besides myeloma and besides melanoma, skin cancer? 1, if you haven't. 2, if it happened before you were diagnosed with myeloma, you had some other cancer other than myeloma or melanoma. And 3, if it happened after the myeloma diagnosis. And Brian's probably going to tell me it could be also basal cell skin cancer. Yeah, so any kind of skin cancer, don't count it. That's just from being in the sun too much. And bad karma. Okay, that's good. So 15% have had another cancer diagnosis. If you were diagnosed, so this is only the people that said that they had a cancer diagnosis besides myeloma. How many had another blood cancer like leukemia or lymphoma? How many had some kind of solid tumor? And I won't read the list of body parts. So we should have about 13, that's about right. Whoa, okay. So they were all solid tumors, which is not terribly surprising. Okay, so we're on for the first presentation. Go back to the podium, please. And we're cool. Thank you, everyone.
Okay, well, thanks so much, Mike Katz. These are very interesting questions. We've been asking these questions for over 10 years now, and it's interesting to see how the answers have evolved a little bit over time. For example, you saw 29% of patients were picked up at the time of a routine diagnosis. And so, as Mike Katz mentioned, the general practitioners, the internists, are doing somewhat better in investigating some really minor changes in the blood or urine testing to come up with an earlier diagnosis. But what this means is, what is myeloma, which is what I'm going to talk about? What is myeloma, the 101 of myeloma? That perspective is changing now, because we're looking at patients, maybe not patients who have very severe bone disease. We are looking at patients who are pretty shocked. They went into their doctor and they were actually feeling pretty good, and here they come out of the doctor's office and they've discovered that something could be seriously wrong. And so we need to change our perspective in terms of how we diagnose, how do we evaluate, and how do we come up with the best treatment options in that situation. So what I'm going to do is start with one thing that I usually never talk about, actually, certainly not in a formal way, is what in the world is it that causes myeloma? And this is frequently the first question that comes to mind, is why in the world I was feeling great, now I've got myeloma. What could possibly have caused that? Well, just in the last few years, there has been evidence in the public domain of some things that maybe could be causing myeloma. And by no means do we have full answers on this. However, we do know that in some cases, there are chemicals that may be involved in triggering or causing myeloma. And we've also learned, and actually through the Bank on a Cure project that was carried out by the IMF and the International Myeloma Working Group, we found out that there are some genetic changes that patients with myeloma maybe have some susceptibility factors. And that susceptibility could relate to the fact that maybe they're not quite as capable of breaking down toxic chemicals. And so, as you know, myeloma is not the commonest cancer, which is great. But the question is, well, why would someone get myeloma from being exposed and then another person might not? And so there is definitely a susceptibility factor. So some people are more susceptible. Now, what happened recently is that it was noted that individuals who happened to be in New York at the time of the 9/11 events are now starting to develop cancer. And one of the chemicals that was present is this chemical right here, which is a petrochemical. It's a solvent-type chemical. And it's something that was present in the environment and could have triggered the myeloma. And so patients with myeloma have become active to try to draw attention to this and make sure that there is an awareness and action. And one lady, Patricia Workman, who developed myeloma, has been very active in this regard in trying to draw attention and to make sure that people fill in the paperwork so that they can have compensation about the healthcare fund. And one thing that has emphasized this is that a study was done and was completed in December, and it was first released in the New York Times. It was published in the Journal of the American Medical Association in December also. And what it showed is that among the 9/11 workers, when you compare them with New York State overall, that myeloma was actually the #1 cancer that is happening in patients who were exposed. And so this is a very important connection, is that whatever those chemicals are, myeloma seems to be something that could be triggered by it. And so this has drawn attention to this aspect of myeloma that we need to be aware of. And we can perhaps come back and talk about that a little bit more later. But as you saw from Susie's talk, in thinking about myeloma, we found that breaking it down into these 10 steps that you see on this slide, which are available on our website, on our iPads, has been quite helpful. And we found that when someone comes to the website, depending on your situation, if you've had myeloma for a while and you've been through quite a few treatments, it could be that you want to start with number 10. You might think, well, my question is, are there any new trials? And so what this has meant is that someone can target their questions and go straight to the one that is most vital for them at that moment. But we also know that when you start at the top, when you go into the doctor's office and you have a lot of questions and some of the lab tests are coming back, that the key questions are, do you have myeloma and what tests could you be getting? And so you can see, we can track this now. And so this is helpful, hopefully, to you. It's also helpful to us because if we know what are the commonest questions or concerns that you have, we can make sure that we try to have as much clear information as possible that could help you in addressing those questions. And so we can see pretty clearly here, if you look at the numbers, you can see that actually the top concern is, well, which tests should you be getting to figure out what's going on? And so we know that that's an important concern, and I'm going to be talking about that. And so you can access information, and a lot of what I'm going to say or show you is actually available on the web, iPad, or iPhone even. So you can check it. Well, not while you're driving to work. We don't want you checking it on that, but you can check it a lot of different places. So some of you who have gone to our website may have listened to Maury Gertz talk about what is myeloma, and he talks about where it could be like a weed patch. And so I think actually it has a lot of merit in thinking about myeloma as a situation where you've got your garden is overgrown with weeds. And so off to the left here, you have your garden that somebody's been taking care of, and you can see it's got a nice collection of different kinds of flowers. So you've got your red cells, you've got your white cells, you've got your yellow cells. Over here, the weeds have kind of taken over and are really completely displacing the normal production in this garden. And there are a few interesting things about the weeds, is that not all the weeds are the same. And so this is something that we've come to realize. This is kind of a new aspect of myeloma that we focused on, and that is that the myeloma cells, when you look at them, they look pretty similar, but then when we treat the myeloma, we find that not all the myeloma is gone sometimes, and so that's because there are different kinds of weeds. You spray your weed killer, and then this one over here, that one doesn't go away because the weed killer is not working. And so we've discovered that frequently the treatment works, but it doesn't get rid of all of the weeds. And so this has brought to attention the idea that we need to focus on treatment that is working in the best possible way and gets rid of all of the different components of the myeloma. And so when the weeds are growing in the bone marrow, what is it doing? Well, it's disrupting all of the normal activities. And so what does that cause? It causes 4 types of things, which is the way that we try to assess if the myeloma is causing a medical problem and if it is at a stage where treatment is needed. And this need for treatment is important, not just at the beginning of the disease, but this is a method of looking at the myeloma that's important throughout the disease. If you're monitoring the myeloma and you've responded nicely, but then maybe the protein level is coming back up again a little bit, then we need to look at these 4 things in the 4 corners of this garden here to see, is there something happening that would warrant a change in treatment or new treatment? And those 4 things are, has the blood calcium gone up? Is there some indication of kidney damage? Is there anemia or low blood counts in some fashion? Or has there been damage to the bones? And those are the 4 things that are the most common things that can occur as a result of the myeloma being active in an important way. And so those give rise to what we call the CRAB features, C-R-A-B. The other thing that we can assess is the number of the weeds in the garden. So the more weeds that you have, the more proteins that are produced. And so this is helpful. We don't need to be testing the bone marrow all the time. We can assess it by seeing how much protein is released into the blood or the urine. And so this is what we call the monoclonal protein. And this is what is measured by, in the blood, the SPEP, SPEP, and in the urine, the UPEP, UPEP. And so if we look at this in a more conventional way, this leads us to what are the tests that you need. And so this is an introductory summary. So step number 2, what tests do you need? Well, to check out what's happening in the garden, you need, unfortunately, to check the weed patch, and you need to do a bone marrow. You need to get some of the bone marrow out and take a good look at it and see if it does have myeloma cells in there. And we're interested in 2 kinds of things. We're interested in how many, so we're interested in what percentage, and we're also interested in some of the features of the myeloma. And so at the time that the bone marrow is done, it is important to send it to the chromosome lab for what we call the FISH testing. So this is a fluorescent test, so that this is where we stain the cells, and this has to be done right at the time, unfortunately. And depending on the chromosome, they light up. I'll show you in a moment. They light up in different colors, and so we can see which chromosomes are there, if they're all there, if they're moved around, and so if there's any problem on the FISH testing. And so we can see how many and if they're normal or not. So we can tell the number of the weeds and the type of the weeds. So the number is reflected also by these things I was mentioning, the SPEP and the UPEP. You can also look at the immunoglobulin levels. Now, this is looking at the broad level of the immunoglobulins, QIG it's called, and this is where on your lab test it shows you the IgG, the IgA, and the IgM. But actually, with regard to the myeloma, it's more important to have this SPEP test, because that is the amount of the monoclonal protein. And so this is the amount of the IgG or the IgA that is specifically coming from the myeloma. And so that is the most important way to measure the exact amount of the myeloma. On the chemistry panel, you can see the calcium, the creatinine, which is the test for kidney function. You can see your regular blood counts, and then what I'm going to talk about a little bit is you can get x-rays and scans to figure out what is going on with the bones. And so these are the real pictures, and so this is what the garden patch looks like when you pull the sample out of the bone marrow. When you take that sample out of the bone marrow, this is what we see, and it can be filled up with these cells here, and that's what myeloma cells look like. And there is, you can see that, you maybe can't tell what those cells are, but you can see that they're not all the same. And so there is this like heterogeneity, even sometimes at this morphologic level. So you can see like different types, sizes and shapes of cells, so that you have this sense of heterogeneity even when you just look at the bone marrow. And when I first started looking at the marrow, it is amazing. When the sample came into the lab and I became familiar with it, I could tell which patient it was just from looking at their bone marrow, because the cells looked different. I could say, oh, well, this is Joe. Yeah, he came back in the clinic today. I didn't realize he was coming in today. You could tell it just from looking at the bone marrow that these cells have a particular size and shape. The cells produce this protein, which is a monoclonal protein, and that's because it has this church spire type appearance here, where it is all of the one type. And so this is what we're looking for. Is it there? And then how much is there? And then something I want to talk about a little bit is that up to now, we've been focused on myeloma as something that we diagnose when we see a lot of these lesions what we call lesions in the bone. These are areas where the myeloma has been active and has damaged or destroyed the bone and causing holes in the bone. And that's pretty scary. And one of the ways that the focus in myeloma has changed is that we used to diagnose myeloma pretty much exclusively. This is the classic feature of myeloma. Now we're focused on, we want to prevent that from happening. We don't want you to be having that. We want to diagnose myeloma before you have those holes, before you have collapse of the vertebra in the spine. We want to be diagnosing myeloma earlier. And this is a key aspect of myeloma, is the early diagnosis. If you have pain, we want to see what's going on in the vertebra before it collapses. And so we're more interested in doing a PET scan where it lights up, or an MRI where we can see spots or sometimes just diffuse involvement of the bones. And that tells us that there's a problem. But we want to see if there's a problem before it turns into pain or collapse or something that really could be important in changing your quality of life moving forward. And so I especially like the PET scanning, and this is a PET scan, and so you can see spots throughout the whole body. And we have come to realize that this is truly a part of the disease. It is multiple myeloma, and we do see these spots, and that is a natural feature of the disease. But as I'll show you in a moment, the good news is that we can see all those spots going away, and frequently we're focused on maybe one or two spots that seem to be really resistant weeds that just are not wiped out by the weed killer. And so we can see those changes at the baseline, what we call focal lesions, or more diffuse changes where you can see all these kind of light up more diffusely. You can also find spots like here, which are not necessarily in the bone. So for those of you who were here yesterday, we talked about how you can see in the bone, but possibly also in the soft tissue. We're alert to that. Now, as far as assessing what is the situation with your myeloma, some ways of finding out, is your myeloma active or slow or more aggressive or less aggressive? One way to look at it is with these two tests that I have on this slide. As the myeloma protein goes up, as the myeloma increases, as the number of weeds in the garden increase, the spike goes up. But what is the behavior? How can we figure out, are these really aggressive, treacherous weeds, or maybe just like smaller weeds? And so this can be indicated by the serum beta-2 microglobulin, SB2M. And this is a simple blood test that most all of you have had, I'm sure. And so as the myeloma is more active, the beta-2 goes up. At the same time, the albumin goes down. And that's because as the myeloma is growing, it produces a growth factor called IL-6, interleukin-6, which travels through the bloodstream, and it decreases the production of normal albumin protein in the liver. And so this is an effect on the liver, what's called a distant effect, which occurs when myeloma is active. And so we know that that is not so good. So we look to see, has the beta-2 gone up and has the albumin gone down? And this is the basis for what we call the ISS staging, where we can have a low beta-2 and a normal albumin, or at the other end of the scale, we can have a beta-2 which is above 5.5 and the albumin is below the normal range. That would be stage 3 versus stage 1. But as I said, we are quite focused now on the fact that there are different kinds of weeds, and oftentimes we can get rid of the weeds, a lot of the weeds, but maybe not all of the weeds. And so at a more sophisticated level, we're studying, and you can see here, this is the different colors of the chromosomes. So you can see the 22 chromosomes there, and they've got different colors. So even doctors who are not quite so smart, I mean, at least we've got a color code here, you know. You know, you say, oh, well, you know, are the yellow ones there or not, Brian? Okay, just focus on that. So we can see the different colors, and then we can also see, it's pretty simple, it's that right at the very beginning, is there one or two? You know, we can deal with that. Is there one or two? And so when we say that there's 13 minus, that means that this one over here, the blue ones, the light blue ones, instead of being two, there's one. So we can handle that. There's only one blue one, all right? So that's 13 minus. Then we can also handle if there's a piece, this is the green ones here is number 4, and then the red ones over here are 14. So if we see the green ones are linked with the red ones, that's called 414, where a piece of the green moved over and linked up with the red. So we can see that. So these little bits and pieces move around. And so you can tell that that could cause a problem, possibly. And so this is what we're looking for. At a more sophisticated level, we can see if the genes are active overall. If a gene is active, it shows up red on this kind of a plot. So if a gene is turned on, those are genes that would be making the cells grow. If the genes are turned off, then obviously that would tend to slow down the growth. It's less active. And so we look to see which genes are red, and then that gives us an indication of that could be a problem. And we see different patterns, combinations. We see that there's yellow mixing with the blue. There's some that are up red, some that are down green. And there are lots of different patterns. There are actually individual patterns. Just like when you look at the bone marrow, I could tell this is Joe. He's got lots of red over here. I can tell that. And so we are able to assess that at a fairly detailed level. The other thing that we've realized about myeloma is that it does kind of morph over time. And this is one of the things that we're looking at more and more because we want to have successful treatment. And so if these different weeds have different colors, you can see here I've used different colors on these circles. And this is from a paper that was published in Blood this past year. And so you can see here at the beginning, the color was mostly this kind of orangey color. And you can see if you give different treatments over time and come around this circle, ultimately what's taken over is the blue ones. So what we know is that there are two things going on here. One is there's a little bit of blue, you know, if you've got really good glasses, there's really a tiny bit of blue here, which ultimately has just hung around. That's been a resistant weed that ultimately is the one that takes over the garden. But the other thing that happens is that the red ones and the green ones, they also kind of morph a little bit over time, and they can be problematic. And so we need to deal with two things. We need to try to get rid of all of the weeds, and we need to try to prevent them from morphing. And so this is the two types of emphasis that we have in the treatment. One is to get rid of as many as possible, but then what we talk about a lot, which is maintenance. We need to prevent any that are left from having a tendency to pop back up again. So an ongoing therapy. And this is very, very important in the meantime. And we have drugs like Revlimid and Velcade that can be used in that way to keep the benefit and stop new colors from popping up. And so every patient is a little bit different. There can be an IgG spike, there can be an IgA spike. There can be different stages. Some patients now do not have bone lesions or maybe have very little. Some patients might have a big, big problem with their bones, and that's particularly difficult and troublesome. Then there can be other factors that we pay attention to. The age of the patient. Is it really possible to do a bone marrow? Well, as you heard yesterday, age is not a factor. You know, 88, no problem. But, I mean, that's just not true across the board. I mean, there are things that do happen with age, and not everyone who's 88 could have a transplant, whereas most everyone who would be 20 or 30 years old probably could. But we look at the other tests and see, well, what are the factors? And so we do two kinds of things at the beginning. We do the staging, using the system that I developed many years ago, which is based upon the number of bone lesions, the anemia, the amount of the protein, and things like that. It's very what we call a clinical staging system that assesses the impact of the myeloma on you. And then the prognostic staging system, which is this ISS staging system, which really predicts the longer-term view. It indicates if the myeloma is aggressive, and so it gives us a better perspective if you're going to be someone in remission for 5 years, 10 years, or longer, perhaps. I have to say, I was really impressed. I think that there must be some pretty good doctors down here in Florida. The majority of the patients in the room had had myeloma for over 5 years. So I think it's a combination of good doctors and good patients, maybe, right? But it is a reflection. At our ASH meeting in December, Dr. Kumar from Mayo Clinic, he updated our data. And so now the new median for myeloma is that we expect patients to live at least 7 or 8 years. This is the new average that we're looking at. And it's improving. What he's shown is it's improving every year with these new agents. So the expectation is just getting better and better, despite some cases where we need to be cautious about the chromosomes. So during the day, you're going to be hearing next about treatment where we don't use transplant. Then you're going to be hearing about treatment where we do use transplant. And then we're going to be talking about the management of bone disease and then the new drugs. And so there are different aspects that we focus on, and we're going to talk in more detail. What I'm just going to talk about now is the fact that when you're first diagnosed, you just need to work slowly through the different steps. The first step is to really think about whether you maybe would be willing to do a transplant or whether it's necessary, maybe or not. You need to try to get a handle with your doctor on how does your myeloma look in the range of things. And so I would encourage you to do that, to get a sense of what is your type of myeloma, what did those different tests that I've showed you look like in your case, so you have a better perspective. So you need to get that information together. Keep copies of your tests. My cats told you you have to do that, right? They are your tests. When you're talking about treatment these days, we absolutely want treatment that's going to work the best. However, we're expecting you to be around for a long time, and you should be expecting to be around for a long time. So we don't want you to be having neuropathy if we can avoid it. And so proactively, you need to be aware of this. You have the treatment that works, but if you're starting to get neuropathy, talk to the doctor about it. There are options. You can take that Velcade sub-Q. You can take it once a week as part of a combo. The best way to avoid neuropathy is to not get it in the first place. As you heard, it's hard to manage. We want you to not get it if we can. Dex, well, we do use it, and, good luck to your spouse. We try to keep the dose down, but we frequently can't eliminate it. There is a risk of blood clots, and we try to avoid those with blood thinners, aspirin, or something more if we think there's a higher risk. And infection is a concern for myeloma patients, and you need to be alert to that. If a myeloma patient gets fever, that's not a trivial thing. We pay attention to that. You need to get checked out. It may be we need to give you a short course of antibiotics. It's better to be on the safe side when you're a myeloma patient. Call the doctor, go into the urgent care, just say, look, I've got a fever, what do you think? Is this okay? That's a very important thing to do. The biggest adjustment is that this is not a trivial disease. It's a very frightening disease. As Susie often says, this is a disease that you couldn't spell, you never heard of before. And so that's certainly scary. It's very frightening. But, as we've been telling you, there is tremendous hope these days. This is something that is not a trivial thing, but there's huge hope. We can treat the disease 95% of the time. You're going to have a fantastic response, and this could be for many years. And so, nonetheless, to make this transition from where you're terrified to where you realize that, okay, I can deal with this, we're going to get through this, and the treatment's going to work, it just takes time. You need to allow yourself to work through that and draw upon your resources to make that happen. And that's one of the things that can happen in these kinds of meetings here, is that you can see someone who's had myeloma for 10 years. And so this is just not a possibility. It's someone sitting right across from you who has dealt with that. And so take advantage of that opportunity to chat and say, well, how did you deal with this and what happened with that? And allow yourself time to adjust. And it happens slowly. I mean, it's not going to happen overnight. Your back is not going to get better overnight. And the way that you're looking at the world is not going to really settle down overnight either. It's just going to take some months, maybe a year or two, until you have a new focus, a new way forward. Make sure that you take care of yourself, and this is important for your spouses as well, that your husband or wife does need to get the sleep that they need. Now, exercise is also important, which can be hard if you have pain and problems initially, but getting back into some level of exercise is important because that strengthens your bones, and so this is quite important. So one thing here is that getting good sleep may also help keep your weight down. I think the thing there is that if you're sleeping, you're not eating, you know. But as some of you have seen, I've given a couple of talks recently, and I have some blogs. I think that it is important to be focused on what you eat, and I think real food is definitely important. And I wrote a blog. One of the things that got me interested in this, and this was an article that some of you may have seen in the New York Times. It was an article about the island where people forgot to die. And I don't know if you saw that. This was about a place where people lived to be over 100. And so this did catch my attention. Now, I wasn't even sure that I wanted to live to be 100, but but I thought, well, this is pretty good. I wonder why that is. And I've written a few blogs about that. And it's not the whole story, but some of it is related to food. And this is a particularly good book, actually. I would recommend it. And it's what you eat and what you drink. I would say one key thing about what you drink is that sodas are really to be avoided. They have the corn syrup in it. They have a lot of chemicals in them, especially the diet sodas. So I would just draw your attention to a lot of people love sodas, but I mean, I just do not think they're the healthiest thing to be doing. And a lot of processed food. It can be hard to have real food all the time. You know, you might need to have a hamburger, but I mean, and I have to watch out. Susie's always watching to see what I'm eating. But I think that it is an important aspect of what you're doing overall. Be careful about supplements. There's definitely the idea that some vitamins and supplements can help you, and many times they can. But you possibly have heard that green tea has chemicals in it that could interfere with Velcade treatment, and so you need to not take that on the same day as your Velcade shot. And so if you're taking extra supplements or vitamins, talk to your doctor about it. I know that many of you are, and just make sure that they're not interfering with any treatment that you might be taking. And all of this is super stressful. However, to the extent that you can, cut back on aspects that you can cut back on. Maybe don't go visit those annoying relatives. I don't know what the stress might be. But, you know, just focus on it. And there are some things that you can do to reduce stress, and it is going to be helpful. And so the other steps you're going to hear about as we move through the day. We're going to hear about deciding about transplant, what other supportive care should you be taking, your monitoring, and the like. The one final key thing that I want to focus on is, as you're taking treatment, how do we know that it's working? And so the key thing is that you need to get that SPEP, you need to get that UPEP. We need to find the level of that monoclonal protein in your blood or urine, or maybe both, because we want to know how much is it coming down. Has it dropped in half, which we call a partial response? Has it come down 90%, which we call a very good partial response? Or has it come down essentially to zero, which we call a complete response or a stringent complete response, where we might do a bone marrow or a PET scan to make sure that's for sure. But this is important because we know that, so this is not 100%, but we definitely are aiming to get that protein as low as possible to have the best possible chance of a long outcome. And so these are the key bits of information that you need to know if the treatment is working well. And then we're going to talk about, do you need to take more treatment to consolidate or to maintain? Do you need other tests to track the response or relapse? Is there a need to change the treatment, or has it worked well enough? So these are important things that you need to ask your doctor. How are you tracking my myeloma? You know, and did you get my test back? Did you order my test? And so that you're really on top of it. But what we can see here in the room, and I think it is incredibly important, is that you need to get support. You need to help each other get through this. And we want, as the IMF, to be part of that equation where we can be one of the sources that can provide the support that you need to help you get through this. So thank you very much. Okay, so I don't know, we have time for questions? I guess we do. Of course. Now, I know that Dr. Kyle was here. I don't know if our other speakers are here. We have a fantastic panel for you today, Dr. Lonial and Dr. Richardson. Okay, so Sagar and Dr. Kyle, if you'd like to come up to the panel, we can, you okay with that? I don't want to interrupt your breakfast.
So how it's going to work, for those of you who weren't here yesterday, we just throw it open and it becomes crazy. No, we go around the room, starting here, one question from this section, one question from this back, middle, back, and front. And please keep your questions to like a single question, not like a question within a question within a question within a question. Because we want to make sure there's a lot of people here, and we want to make sure that we get to as many people as possible. So we're going to start from my section. All right, lady in the front row.
Sagar, good to see you. Thank you. Giving up diet sodas. Now, many of the flavored waters, are sweetened with nutria. Right. Do you approve of that?
I think that the simpler you keep it, the better. I think that just regular water is good. If you want to take something, you take it, you know. But anyway, I know that this is a particularly sensitive area. All I can say is that if you want to do the best possible, the sodas and the sweeteners are not ideal.
Okay, in the back?
Anybody in the back with a question?
All right, Suzanne, when do you go?
Okay, right here, doctor.
Actually, while we're waiting, I could ask Sagar, who comes from Atlanta, the home of Coca-Cola. And so I don't know what his perspective on sodas is.
So, I mean, I think, and I guess as a disclosure, our university is supported by Coca-Cola stock, so you can interpret what I'm going to say however you'd like. I think simple is good, but I also think moderation is important. Yeah. I find a lot of patients that try and exclude many of the things that bring them small pleasures in their life, and I don't know that it's necessarily worth doing that if it's done in moderation.
Okay, good. All right. So, who's next?
What is the difference between consolidation and maintenance after transplant?
Okay, so consolidation is a short course of treatment, intensive, to try to bring the myeloma down, to maybe eliminate whatever myeloma is left. Typically, it would be after a transplant. So the definition is that it's a shorter course, 2 or 3 months, more intensive. versus maintenance, which is low dose tablets, or maybe the sub-Q Velcade now, or something else oral over a longer period of time, more like 1 year or 2 years. So you've got short and intense versus more gentle and long. Of the different, maybe someone could comment on this, of the different strategies that we have, we probably have the least data to kind of show the value, the specific value of consolidation. And so, someone want to comment on that, about the value of consolidation? Do you give consolidation at Mayo, Bob?
In general, no.
Okay. All right. There we have it. How about Atlanta?
Yeah, so I don't think we specifically give consolidation, but we give long-term maintenance in many of our patients. And so I think the Europeans have brought this concept of post-transplant intensive therapy followed by a maintenance phase, and they call that post-transplant consolidation. There is a fair amount of data that suggests it's interesting, but if you do short-term maintenance, then consolidation may be more important than if you do long-term maintenance. So.
Yeah. Okay.
Okay, we have a question over here in the back.
All right.
In a case of non-secretory myeloma, what is the best testing method since you're not getting an M spike?
The spike, right. About 70% of patients will have an increase in the free light test, so the kappa or the lambda in the blood. And so in those cases, we can use that free light test. But still, some of those patients, the free light is normal, the beta 2 is normal, and so then it can be quite difficult to monitor, and we need sometimes more frequent bone marrow tests. I actually especially like the whole body PET scan to see if there are lesions anywhere, or MRI testing. So for true non-secreting myeloma, you often have to do bone marrows or imaging. So what are the protocols for you guys? Is it similar?
Yes,
Yeah.
basically.
Yeah. Okay.
Kel, do you have a question?
A quick short list, please, of the other cancers to be on watch for and the rough percentage that myeloma patients could expect: CML, MDS, amyloidosis.
Excuse me, so you're concerned about what percentage chance would a myeloma patient have of having one of those things?
Yes, either from treatment or just concurrence, like amyloidosis. I think at one time Mayo did a study and
Yes, yes.
Yeah.
Okay, so actually Mayo presented a study at ASH this last year where it looked at hematologic malignancies, leukemias, MDS, actually in patients with MGUS and smoldering myeloma. Do you want to comment on that, Bob?
Yes. We looked at a group of patients with monoclonal gammopathy of undetermined significance, MGUS, and smoldering multiple myeloma, and found, in short, that the risk of myelodysplasia, acute leukemia, and the like was about 2.5 times more than what one would expect in a normal population, at least in Olmsted County, Minnesota, which is our home base. So there is some risk. There was a study published a year or so ago from Sweden that reported a higher risk in the range of 7 or 8 times above that level.
Right, right. So there is some joint risk, and it's understandable. I mean, if you just broadly think that a chemical, just by way of example, if a chemical is causing damage to the bone marrow, it's hard to envisage that it would damage one cell and maybe not have an impact on some of the other cells. Okay.
Okay, we're going to have a question over here.
Approximately 50 years ago, I worked for a chemical company in the laboratory where Tylenol and toluene and benzene was. And at that time, I got very sick. They thought I was having hepatitis, but I think it turned out to be mononucleosis. But the point I'm asking here is that is it possible to have MGUS at that early stage and have had it for 40 or 50 years before it flared up into something like multiple myeloma now, or stage 2? Could I have had it for 40 years or 50 years?
So I think the answer is yes, and again, my colleagues can comment, but we did touch on this yesterday. I think that the key papers came out the last couple of years where it was shown that if you look at patients with myeloma and you happen to have blood samples in the years before, like 5 years before, 10 years before, and you look at those samples to see was there an MGUS before the myeloma popped up, I think the unexpected answer was that virtually in every patient there actually was evidence of MGUS that extended back 10 years, and I think that one of the key research questions now is, does it extend back 10 years or maybe 40 years? Should we be testing children? I mean, I don't know. I mean, how far back should we look, Bob?
Well, we're in the process of looking back to age 10. We've published a study a few months ago in which, with sophisticated mathematical equations, we came to the conclusion that a patient who walks into his or her doctor's office at age 70 years and is found to have an MGUS, a completely asymptomatic MGUS, that patient has had the MGUS for an average of 16 years. Now, if you had asked me a couple of years ago or so, I would have said, well, gee, maybe 2 or 3 years or something like that. But I think the truth is that the MGUS has been going on for a long period of time. And then to address the question about benzene, there's been a lot of controversy about whether benzene plays a role in multiple myeloma or not. And in general, the real evidence is very, very weak. Now, as far as other chemicals are concerned, we had the opportunity a couple of years ago to, in conjunction with Dr. Ola Landgren at the National Institute of Health, he was able to get sera, blood samples, from patients in the state of Iowa and in the state of North Carolina who had been exposed to large amounts of insecticides and pesticides and so forth. We examined that 700 or 800 patients who had the high exposure to chemicals for the presence of an MGUS in their serum. And then we age and sex matched that group of patients to our epidemiologic group in Olmsted County, Minnesota. And the risk of MGUS in the persons who had been exposed to various chemicals was between 2 and 3 times that seen in Olmsted County. And in fact, some of the specific chemicals produced a risk of 6 or 7-fold times that in Olmsted County. So there's no question that insecticides and pesticides can play a role in the development of MGUS, which, as Dr. Durie told you, is found almost all cases of multiple myeloma if one looks at the blood of a patient years before the diagnosis of multiple myeloma. In fact, in our experience in another study, over 80% of patients who had multiple myeloma had an MGUS in their serum 5 years before the diagnosis of myeloma.
So,
Thank you so much for that summary. Just a quick comment. Yes.
Yeah, so I think The association, obviously, with exposures, we see this in Georgia a fair amount as well with insecticides and pesticides. Well, I guess one of the things that I think it's important to realize is that having MGUS doesn't mean you're going to get myeloma. Right. Having myeloma means you probably had MGUS before, but all MGUSs do not become myeloma. And so while the risk may be higher, it doesn't necessarily mean the risk of developing myeloma is that much higher as well.
Right.
Yeah,
This is a very key point.
That's a very important point, and you're much more, with an MGUS, you're much more likely to die of heart attack, stroke, other cancers than you are multiple myeloma, Waldenstrom's macroglobulinemia, or AL amyloidosis.
Absolutely.
If you live to age 150 years or so, then the risk obviously would be considerably higher.
Yes. It's basically 1% per year, right?
Yes.
1% per year. So, anyway, yeah, we can move to the island of Ikaria in Greece, where you can get to be 150. All right, I think we need to close with that. So thank you so much. We're going to move forward with our next presentation. Our next presenter is, in fact, Dr. Kyle, who's going to talk about best therapies for more elderly patients with myeloma. So please welcome Dr. Bob Kyle from the Mayo Clinic. We're very, very privileged to have him with us here today. So I'll tee that up for you here. Pointer up here if you want.
Thank you very much, Dr. Durie. It's a pleasure to be here this morning with you and your support givers. It's always very uplifting to me to see so many people that I've seen at multiple patient seminars. Now, as I look at the title slide here, I'm not so sure we have that right. I would prefer another term other than elderly, perhaps the older patients, because I don't consider myself and many of you as actually being elderly. These are my disclosures, which consist mainly of serving on disease monitoring committees for ongoing prospective clinical trials for drugs with multiple myeloma. Now, as Dr. Durie told you, the diagnosis of multiple myeloma depends upon the presence of an M protein, a monoclonal protein, in the blood or in the urine, and that light chain, of course, in the urine is called Bence-Jones proteinuria. And the presence of increased numbers of plasma cells in the bone marrow. Now, that is usually greater than 10%, but a small number of patients with symptomatic multiple myeloma requiring therapy can have fewer than 10% plasma cells in the marrow. Another feature might be a soft tissue tumor, that is a plasmacytoma that consists of abnormal plasma cells. The major criterion, of course, is end organ damage, and as Dr. Durie told you, you can think of that as CRAB for cancer, the C for elevation of calcium, the R for renal or kidney insufficiency, the A for anemia, and the B for bone lesions, no matter whether you see them on conventional X-ray or on CT scans or on MRIs or a PET CT. This is the culprit, the abnormal cell. In fact, if you didn't have it, it looks kind of pretty here, very nicely stained, peculiar in that the nucleus of the cell is oftentimes off to the side, stains very bright blue, and hematologists and pathologists recognize these cells generally readily. And this is the product of your cell. The M spike that you see on your right, on the electrophoretic strip, one sees a dense localized band. And when a densitometer instrument is used to measure the size of these bands, one sees over here a very high peak. That's albumin, of course, and we all have that. And over here is the big spike of multiple myeloma. And by following that spike, which is present in about 80% of patients with multiple myeloma, and the majority of the remaining 20% will have a similar spike in the urine, and that leaves us with 3% of the patients with so-called non-secretory myeloma, but 2/3 of those patients have an abnormal free light chain ratio, so we end up with just about 1% of patients with multiple myeloma who do not have a measurable protein abnormality. There is one entity that I want to call your attention to, and I know that some of you have this. We call it smoldering multiple myeloma. These patients have a large M spike, by definition 3 grams or greater, and or 10% or more plasma cells in the bone marrow. And at first glance, this constitutes the diagnosis of multiple myeloma. However, when the doctor looks a little more closely at these patients, or at you, there is no anemia. Your calcium is normal. Your creatinine, which is a blood test for kidney function, is normal. Bone x-rays are negative, and in short, there is no end organ damage. And this entity, smoldering multiple myeloma, should be followed until it progresses. I have seen patients who have had smoldering multiple myeloma for over 30 years and then died of a heart attack that was totally unrelated. Now, we're making every effort to determine which of the patients with smoldering multiple myeloma are at high risk for developing multiple myeloma, and then those patients should be studied in an effort to determine whether treatment will reduce the possibility of developing multiple myeloma, and most importantly, whether the survival of the patient would be improved with treatment earlier. But at the moment, by and large, patients with smoldering multiple myeloma from a routine basis should be recognized and followed without treatment. This is what happens to patients with smoldering multiple myeloma. Whoops. Oh, this is very sensitive. Yeah. During the first 5 years, the risk of progression is about 10% per year, which is 10 times the risk of progression of MGUS. But after 5 years, that risk falls off, and after 10 years, it approaches the risk of MGUS. So the bottom line is the longer you go with smoldering multiple myeloma, the better it is and the less likely it is that it will progress. However, as you all know, you do have to be followed because progression is a real possibility. When we see a patient with newly diagnosed multiple myeloma, we look particularly at the FISH cytogenetics, and if the patient has a deletion of 17p or a translocation 1416 or 1420, or a gene expression profile that represents high risk, then we place that patient in a high risk category. Now, as some of you may know, there are several gene expression profiles. The best known in this country is the one developed by Drs. Shaughnessy and Barleggy at the University of Arkansas, which consists of 70 different genes. There is one from France that consists of 15 genes, and one from the Netherlands, which consists of 50 or more genes. The only problem is that there is very little overlap in these genes, and I think that is telling us that there are a large number of genes that play a significant role in multiple myeloma. It's not like some diseases in which one gene change results in a specific disease, such as sickle cell anemia or the like. Now, the patients who have standard risk may have increased numbers of chromosomes. They may have a translocation of 1114 or 614. And those patients who have 414 or a deletion of chromosome 13 fall into an intermediate range. We first of all determine whether the patient is a transplant-eligible patient or not, and for the so-called older patient, autologous stem cell transplant is not an option. In Europe, the cutoff is 60 years. In this country, most hematologists and oncologists will look at age 70 as kind of the watershed level. But I want to emphasize that aging does not necessarily depend upon the chronological age of the patient. The physiologic age of the patient is much more important. And there are patients well into their 70s that we perform autologous stem cell transplants on, very often as an outpatient procedure, and these patients can do very well. On the other side of the coin, there are patients who are younger, but who are physiologically more aged, and there are also patients who will have other diseases, such as heart problems, or strokes, or other malignancies, or any variety of things that make them a poor candidate for transplant. For the standard risk patient, we oftentimes use lenalidomide, Revlimid, and dexamethasone at weekly intervals. If you lived in Europe or other countries where thalidomide is much cheaper than it is in this country, your doctor might want to treat you with melphalan and prednisone and thalidomide. And we usually give we usually treat that patient who is transplant ineligible for a year. And if that patient has responded satisfactorily, we will stop therapy and then follow that patient along. And when the disease recurs, if it recurs after a year, then we would go back to the same medication again and get as much mileage as we can from it. And if the patient has progression in a short period of time, we would go on to another agent. If the patient, however, falls in the high-risk group, the high-risk cytogenetic group or high-risk gene expression profile group, then we would give a combination of Velcade or bortezomib and Revlimid, lenalidomide, and the dexamethasone. The reason that we do not give the three agents together is that we like to save something in our back pocket for future use. This is a study that was done in which over 400 patients were with newly diagnosed symptomatic multiple myeloma requiring therapy were randomized to receive lenalidomide, Revlimid in the standard dose, or to receive the Revlimid in the same standard dose and schedule. But here, the dexamethasone was given at weekly intervals. Dexamethasone has been used for multiple myeloma for over 30 years, and we always had the idea that it should be given very frequently, days 1 to 4, 9 to 12, and 17 to 20. But you patients who have even attempted something like this will find that it's almost impossible from the standpoint of side effects. And in this study, at 1 year, the survival was 96% in the patients who had received the weekly dexamethasone compared to 87% patients receiving the standard dose. And at 2 years, this survival benefit, 87% versus 75% for those with the standard dose of dexamethasone was considerably better. And so today, virtually all physicians will give the dexamethasone at weekly intervals instead of the more intensive dose. Bortezomib and dexamethasone is another combination for patients with multiple myeloma at the time of diagnosis. And I want to emphasize two things, actually three things, with bortezomib therapy. First of all, it's been shown that bortezomib can be given at weekly intervals instead of the twice weekly interval that was used initially, and that the results are virtually the same. And we usually give it for 3 weeks and give a week off. Other people give it 4 weeks and a week off, and there is no evidence that one is any different than the other. The other important point to keep in mind is that the Velcade can be given subcutaneously, that is, under your skin. It does not have to be given intravenously. And that makes it a lot better, a lot easier for patients. The third point I would emphasize with the use of bortezomib or Velcade is that if you have numbness or tingling of your hands or feet, with the Velcade, call your doctor right away and let him know. Don't grit your teeth and wait it out, because if you have responded well to the bortezomib, your doctor may reduce the dose or the frequency of its administration. You don't want the peripheral neuropathy because it is a miserable side effect, as many of you know. I would also mention in passing that it has been shown that older people already may have a subclinical peripheral neuropathy. There was a study in which a group of patients above the age of 70 years were examined very carefully by a neurologist who found absolutely no evidence of peripheral neuropathy. But when these patients were subjected to an EMG examination, they found that the transmission of impulses in the nerves of the patients were abnormal in about 25% of these patients. And these are patients who have a subclinical peripheral neuropathy, and I think that many of those patients are the ones who, after maybe a month or two of bortezomib therapy, are the ones who start getting the numbness and tingling and the peripheral neuropathy. On the other hand, there are patients who have taken full doses of bortezomib for months and have never had any peripheral neuropathy. So it is an individual sort of thing. Now, this is a study from the French myeloma group in which over 200 patients above the age of 75 years were randomized to receive melphalan and prednisone in a standard dose here, or to receive the same dose and schedule of melphalan and prednisone, but here 100 milligrams of thalidomide was given. And you can see that the progression-free survival and the overall survival were superior in the patients who had received the melphalan, prednisone, and thalidomide. This is a study from Dr. Palumbo from Italy in which 511 patients with newly diagnosed multiple myeloma above the age of 65 years and were deemed ineligible for an autologous stem cell transplant were randomized to receive a combination of Velcade, melphalan, prednisone, or Velcade, melphalan, prednisone, same dose, same schedule as this, but thalidomide was added. And then after 4 courses, 4 months of therapy, these patients were continued with Velcade and thalidomide. And we see that the partial response was a little better with the VMPT, better than the VMP, and at 3 years, the progression-free survival was better with the maintenance Velcade and thalidomide. But at 3 years, the overall survival was virtually the same in both groups of patients. This is a study of over 600 patients in which the patients were randomized to receive bortezomib, Velcade, melphalan, or to receive melphalan, prednisone, and these patients received just the melphalan and prednisone alone. And when we look at the results, we find that the patients who received melphalan, prednisone, Velcade had a 30% response, complete response, which is really very good, versus 4% response for the melphalan prednisone patients, and the partial response was twice as high in the MPV compared to the melphalan prednisone alone. And also, as you might expect, the duration of that response was superior in the patients who received the melphalan prednisone and Velcade. Now, there were side effects, as you might imagine, and those patients who received the Velcade in addition to the melphalan and prednisone had a little more neutropenia, a little more thrombocytopenia, and not any more anemia. And they did have some more gastrointestinal symptoms, but these were really not a major problem. But the major problem from the standpoint of the patients is that 13% had grade 3 peripheral neuropathy and less than 1% had grade 4. But you as patients are well aware of the fact that patients with grade 2 sensory motor peripheral neuropathy are quite miserable, and even grade 1, which is the minimal level of peripheral neuropathy, is not a pleasant experience. And overall, between 35 and 40% of these patients had some peripheral neuropathy. This is a study that was published in the New England Journal just last year by Dr. Palumbo. 459 patients with multiple myeloma, newly diagnosed, transplant ineligible, were randomized to receive either melphalan, prednisone, and Revlimid, and then after 4 cycles, these patients were put on maintenance Revlimid, or to receive melphalan, prednisone, and Revlimid, or just to melphalan, prednisone alone. And we find that the progression-free survival was 31 months in those patients on maintenance, considerably better than either of the other 2 regimens. And however, at 3 years, the overall survival was a little better with the maintenance patients, but not significantly so. But there were 7% of the patients who were on the maintenance Revlimid who developed second primary malignancies, that is, cancers of the lung, breast, prostate, colon, and so forth. Patients on MPR, also 7%, compared to those patients who had melphalan and prednisone, which was only 3%. Now, this is something to alert you to, but in the big picture, the risk of secondary primary malignancies, at least so far, is quite modest and is not an alarming finding in these patients. This is a large study on patients who had relapsed and refractory disease. The patients were randomized to receive lenalidomide and dexamethasone. As you can see, this is in the standard dose, or a placebo and the dexamethasone, same dose, same schedule. And you can see that those patients who received the Revlimid had a much better response, and the time to progression of their disease was also superior at 11 months versus 4.7 months. Now, to summarize this, my colleague Shaji Kumar looked at our experience from 1971 to 2006 and simply divided the patients into 2 groups. Those patients who were diagnosed after 1996, these were patients who by and large had received autologous stem cell transplants or the novel agents, that is thalidomide, lenalidomide, or bortezomib, and compared their survival with those patients treated before 1996, and these patients were treated with melphalan and prednisone, or more commonly, combinations of alkylating agents. And you can see that the survival in those patients diagnosed later was 44.8 months, going on 4 years, compared to 2.5 years for those patients receiving the alkylating agents. And this survival of 2.5 years was the general survival that we've seen since the introduction of melphalan in the early 1960s. Dr. Kumar updated this information. In our patients from 2001 to 2005, and then from 2006 through 2010. And here, just in that 5-year period of time, the survival has increased considerably, 66% at 5 years compared to 47% at 5 years. And in the days of the alkylating agents, it was about 25% at 5 years. And you will hear later today about these novel agents, pomalidomide, carfilzomib. There's an oral proteasome inhibitor, NPI-0052. Another that can be given orally or intravenously, MLN-9708. Eltuzumab is a monoclonal antibody to CS1 that is in the middle of a very large clinical trial. Bendamustine is another drug that is active in multiple myeloma. Interestingly, this drug was developed in East Germany in over 40 years ago, because the alkylating agents such as BCNU that were used in the Western world were too expensive. And so they developed this cheap drug, bendamustine. And if any of you have had bendamustine, it is far from cheap today in this country. There are over 50 histone deacetylase inhibitors that are being looked at. The most senior ones are vorinostat or SAHA, and now a very large study has been completed with panabinostat, and we're awaiting the outcome of that study. So in short, you're going to hear a lot more about new agents this afternoon, and this is a good time, an exciting time for patients with multiple myeloma. And with that, I thank you very much.
So thank you so much, Bob, for that overview about therapy for elderly patients. I've learned that I guess we don't have time for questions immediately, so we're going to take a break, and then we'll be... You did not run over. I think I probably ran over. Okay, so...
It was well worth it. Well worth it.
Okay. So that's right, Susie. What time will we be back?
Oh, I'll come get you. Don't worry.
All right. So stretch your legs, have a little bit of a break, and we'll regroup in about 15, 20 minutes. Thank you.
Very good.